Hi everyone. So for this part of the session, we'll actually talk a little bit about the different subtypes of hypertension. So the ones that is covered in the other class is actually on the general, i.e. the systemic hypertension, whereby you can measure an elevation of the blood pressure at the cuff that we normally use, right? So this one, some of it is still the same, but there are some subtypes. So which actually indicates a little bit different in terms of its management. So you've got something called pulmonary hypertension, and we've got hypertension crisis. Actually, hypertension crisis is the normal systemic high blood pressure, but it's just that it happens in a very sudden and the value is way too high that you need to keep it under control pretty quickly. And also in pre-eclampsia, which refers to the hypertension during pregnancy. Right, so um, pulmonary hypertension is something very localized, so whereby it only happens mainly at the pulmonary blood vessels, right? So meaning they in the systemic blood circulation, you can't actually measure a change. So it's pretty normal in terms of their blood pressure. So this is when the situation occurs whereby some females or pediatric patients are actually prescribed with Viagra. So in case you'll be like, huh? Why? So because it's due to the diagnosis of pulmonary hypertension. So it can be multi-factor, so all forcing the heart right side because it's the one that supply bloods to the lungs to pump harder. So and another thing is it's obviously dangerous because there's a lot of smaller vessels. Again, we don't want the vessels to sort of experience too high a pressure that it will cause any burst or whatever, right? I.e. like a mini stroke-ish kind of, but it happens in the lung. Just using the stroke as an analogy, right? So there are three main signaling pathways in the pulmonary hypertension. So we try to use the drugs which is more towards pulmonary hypertension because again you don't want the overall effects of hypotension to be too strong, right? So we've got the endothelin pathway, the nitric oxide, and also prostacyclin. So for endothelin, you can see over here, so endothelin is actually another activates its own receptors, which is another GPCR. So you got subtype A and B, so you can actually put an antagonist over here. So nitric oxide is more to increase the level of nitric oxide in the system so that there'll be some vasodilation, right? And also it can be a direct increase in the prostacyclin, again to promote vasodilation. So we'll go through the first one, which is the nitric oxide one first, sorry. So the second one. So here is where your PDE5 inhibitor. So this is where your Viagra, which is your sildenafil over here. So you can actually use tadalafil or vardenafil as well. So what happens is that it's an indirect one from NO, whereby NO actually activates the guanyl cyclase to cause an increase in CGMP. So CGMP is the one, as you can see, actually eventually causes relaxation. So when you put in an antagonist for its breakdown enzyme, so this is the inhibitor for the enzyme for breaking down, you cause accumulation of CGMP, eventually increase in the smooth muscle relaxation, i.e. vasodilation. Right, so you try to, if the person is also on nitrates drugs, so try to space the drugs out as far as possible in a way, because again we don't want the tolerance to be built up because obviously the system has its own maximum capacity, and we also don't want an over hypotension effect in the systemic hypotension to occur, which can be dangerous to the patient as well, because we don't want the blood pressure to drop so much that the blood supply to the organs will be affected. So there are other cautions and contraindications. Please look them up in the BNF as well. So here, the effect of this inhibitor is actually not as predicted in a way sometimes, because it depends on the effect of this depends on the overall NO available in the system, because some people the NO might be higher, some might be lower. So if you can imagine, if for someone, if the NO in the system is a bit lower, there's not much CGMP that you can accumulate in a way. So therefore the clinical efficacy will be a little bit lower than you predicted. So there's another way to overcome it, whereby they came out with this drug. I think it's called Riosihuat in terms of its pronunciation. So it can be GC stimulator, a direct stimulator of ganglion cyclase. So therefore, it produces a more predictable response. So it's a direct one. So I don't mind whatever level of NO is it, right? So but it's a bit not the most pleasant drug in terms of its frequency, because it has to be TDS. So again, if you can remember, there's not that many drugs available in TDS now for any long-term consumption, because again it might affect the compliance a little bit, right? So so again, it actually causes multiple effects, so it can actually decrease proliferation and also decrease the fibrosis as well, which is good for the disease, right? So we go back to the first part of the first diagram of the tree arm, and we look at the endothelin pathway. So you can actually put an antagonist, as mentioned earlier on. So here you actually need to look at the interplay between the two cell types, when we have endothelial cells and we also have vascular smooth muscle cells. So you see, endothelin per se is actually being released by the endothelial cells, right? Then it can actually activate the endothelin receptors on the vascular smooth muscle cells. So in the vascular smooth muscle cells, you can see there's ETA and ETB subtype, so both can cause contraction. However, there's also actually ETB on the endothelial cells itself as well. So when you activate it, it can also cause relaxation. So you can see that if it will be better that actually if you have a specific ETA antagonist, so therefore you have a little bit more relaxation over here. So based on this, so the earlier generation, you got bosentan and macitentan. So I always find the name quite cute. So these are competitive antagonists for non-selective. Then you got ambrisentan, which is an ETA antagonist, but specific ones. There's a little bit of issue about hepatotoxicity, but it's lesser for macitentan and ambrisentan. So the bosentan is the first one. So, but do bear in mind there's some pregnancy teratogenicity warning as well. And you can see actually the drugs available for pulmonary hypertension, they are quite limited. So even though you can see drugs which you need to take a QID, or just now the one which is TDS, it can still be marketable because the options are just way too limited. Okay, so another part is the prostacyclin one. So you can see there are some direct agonists over here. As mentioned over here, your is ipoprostenol, iloprost, right? Or treprostinil. Sorry, they are not the most common drugs that you can find. So when you directly activate it, as you can see if you look at this arm of it, so you activate your allyl cyclase to cause accumulation in CMP and therefore activation of PKA for direct vasodilation. So there's some explanation for the other two over here as well. So hopefully it's fine. So let's move on to the next subtype, which is the hypertension crisis. So I'm just using a mini case that's an illustration. So meaning it's normally, obviously, because it's a crisis, it's normally being detected in a very fast way. So normally you'll see it in the A&E department, whereby there's a very, very high surge of blood pressure, right? And the person will experience symptoms already because the body couldn't cope with it. There can be blurry vision, nausea, headache, confusion, or the person might be unconscious as well. Depends on the situation. So for this case, the pressure is about 235, 130. So it's something you have to manage pretty quickly because you get all the end organ damage very quickly as well. Remember, uncontrolled hypertension will take years to form all these complications, but in the hypertension crisis, things can happen very quickly in terms of its side effects. So we try to keep it under control as fast as possible in a way, but the pressure cannot be shut down in a way too quickly because again, the body may not be able to take it very well. Right, so there are a few common causes of severe hypertension. So you can look at it just very briefly. So you can see some of it are systemic. There's renal involvement, right? There's arteriosclerotic disease, and bear in mind there's also drugs related, right? And also endocrine, the Cushing syndrome, Crohn, and also some pregnancy related ones. So that's why if the pregnancy ones, you have to actually manage it pretty carefully because the pressure can be very, very high that it can harm the mom and the baby. And if you can imagine, the person could be lying down on the bed for the whole day, but the pressure is still high. Right, so drugs, there are some drugs which are over here, so again you have to bear in mind for some people, so obviously not to overdose on such drugs as well. Right. Okay, so there's a flow chart. This is again the Malaysian guideline. So you can see the pressure could be high. So you can see mainly it depends the speed that, i.e. the targeted blood pressure that you need to hit. It actually depends on whether there's a presence of the acute organ damage or not. So if there is organ damage, it's an emergency. If not, it's just urgency. So you can see if it's an urgency, so you can just slowly reduce it by 10 to 20%, 25% within the first hour, then slowly go down. Right, so if it's an emergency, can be due to these three main specific reasons. So you can see eclampsia is over here. So for this ones, you need to reduce the blood pressure as soon as possible. So it's a much stringent kind of effect that you want, right? So you can see if it's just urgency, you can actually just rest first, right? And obviously try to continue the medication that the person is taking, right? So if they are responsive, the pressure just go down. So meaning it's just a very high pressure just for a short period of time. So maybe the person is calm enough, obviously the pressure will drop as well. So it can be back, right? If not, then you probably have to start the anti-hypertensive. So but in this case, it could be it refers to the IV form actually, because then you can check the pressure every half an hour to an hour. Right, so here, why am I specifically splitting up the topics of the normal hypertension and the crisis ones? Is because of the medications. Obviously, the medications that we'll be using over here are mainly in IV form, so you want the effect to kick in very quickly. And if you accidentally give too much of the drug, the pressure drops too quickly, you can just stop the infusion and the response can slowly go back, or reduce the infusion, then the response will be pretty quickly as well in terms of its reversal in blood pressure. Right, so you can see quite some names over here. Some of it are quite something that you know. So you can see beta blockers play quite important role as well. So over here, labetalol is actually a first line treatment. So go find out the ratio. It's actually over here as well. It's actually non-selective towards alpha 1 and beta, and you have a ratio 1 to 7. Right, so there's some oral treatment for urgency ones, so you can actually use some of it. Right, so there's some clinical situations over here, so you can just go through them. Details, if you prefer to read text, you can obviously refer the guidelines again. Right, so these are some causes and some of the targets that you need to know. Right, so there you go. So again, in urgency, the pressure can go down slowly. You can afford that because there's no acute and target organ damage, right? To go down in hours, but emergency you might need to do it in minutes. Okay, so for the third subtype that we're going to go through is about pre-eclampsia. I won't really say so much about it because in the clinical side there'll be a separate class and case study on pre-eclampsia and eclampsia. So this is just a very quick overview. So meaning for some reason, we don't know really why, that some pregnant people actually get high blood pressure and proteinuria, right, during the late second or third trimester. It's a bit unpredictable in a way because a person might get it in the first pregnancy but not the second one. So you can see the drugs that we use here. So the main thing is we try to make sure that the drugs that we use is safe for the woman and the baby, for the mom and the baby. So this is using this chart just to remind you that the famous ACE inhibitors or ARBs is actually contraindicated, so you should not use them because it actually cause fetal abnormalities. So remember the favorite ACE inhibitors and the ARBs is not to be used during pregnancy. So I actually use those very old drugs like metaldopa is a really old drug, right? Labetalol and the others are relatively older drugs and they're shown to be much safer profile. Right, so you can actually go through this blog. It's an older post, but it's actually quite nice in a way. It actually tells you the story from the mom's point of view. Right, so you can see the guidelines in a way. You can use hydralazine and things like that. Okay, so there could be convulsion episodes for them, so you might need to use some other drugs as a top-up as well. Again, all this will be mentioned a little bit more in the pre-eclampsia topic per se. Okay, so now we look through a little bit on the pharmacology part of the metal-dopa. As mentioned, it's something that acts in the central nervous system. So the effects, as you can see, is not really used for the other kinds of hypertension, just because of there's more episodes of giddiness and so on. So how does it work? So metal-dopa is an analog of dopa. So it can go through the whole system and replace the endogenous dopa, right? So therefore you have lesser amount of norepinephrine. So it can also act as an agonist to the alpha-2 receptors as well. So therefore it causes an overall decrease in the noradrenaline signal as well in the whole body. So therefore you have lesser vasoconstriction, right? So metal-dopa, so why is it not being used so much? Because there's quite a bit of side effects on the hepatotoxicity and things like that, and also you have to be careful, and there's some history of depression as well, so a lot of side effects, so it's not the most commonly used one now. Again, it doesn't help so much in the long-term mortality in the systemic hypertension kind of situation. So again, just to mention the last one, sorry I didn't put in the first slide. So it's portal hypertension. So because we'll actually look through a little bit more in the GI class. So portal hypertension is similar to the pulmonary one, whereby it's a localized hypertension. So it's commonly caused by liver cirrhosis, therefore influencing the blood flow in the whole liver system, so that it's not, so therefore the flow is not so good, so therefore there's some resistance, therefore the pressure goes up. So it can be lethal in a way, because obviously it affects the microcirculation. You don't want hemorrhage to occur, so we can try to give them a low sodium diet, right, and also diuretics. For primary prophylaxis, can be a surveillance, so you can use beta blockers or ISMM when you need it, and you can combine them when required. Right, so just a little bit of newer drugs in hypertension. There's a lot of people a lot of companies who try to improve the compliance of the patient. So therefore, they actually make tablets which have both things. But this is like it's not a chemical combination. So basically, it's a combination during the manufacturing process. So maybe they already stabilized on one of the drugs and then just top up. So then you can just change into a one tablet kind of preparation, right? So remember what you're giving in combination, so you don't give any top-up drugs which is similar or in the same class as well, right? So we also have this one, which is going to mention a little bit more in the heart failure class. So this is a chemical combination of valsartan and another neprilysin inhibitor. So therefore cause vasodilation. So it could be later on be licensed for hypertension use. There's also another one called aldosterone synthase inhibitor. So just to show you that the different pathways that can be targeted for hypertension. So you can actually give an inhibitor over here to inhibit the enzyme of the production of aldosterone. So therefore again causes an overall vasodilation effect that you could use in hypertension or maybe in heart failure conditions. So again, depends on the outcome of the clinical trials. So thank you for listening. See you in the next round.